Okay, well, good evening, everyone. I hope you've had a fantastic Tuesday. Um, we are here for our Hawaii State Center for Nursing Board meeting this afternoon. Again, thank you for all for joining. We are excited. We have a special guest today, Kelly Johnson, the Senior Vice President, Assistant Chief Nursing Officer at Queens Hospital System. She'll be joining us to do a special talk story session on nurse well-being and resilience programs. So again, we're excited this evening to have a special guest. Are there any announcements? First thing, or roundtable items? Any introductions we need to make? Okay.
No, this is Laura. I do want to welcome our board members that were approved for next session, which starts after July 1st. So Gloria Fernandez, Linda Beechnor, and Roberta Haley, thank you for being here. Right now, it's a voluntary activity.
Yeah. Well, thank you, Gloria, Roberta, and Linda, for joining us again this evening. May the 17th here as we move forward with our agenda. Any other introductions, Laura?
No, I don't see Kelly Johnson here yet.
No, I don't. I don't see
Well,
her.
we can, if the board feels comfortable, I can start giving the legislative update to make use of everybody's time, and then we can give the time back to Kelly.
That'd be a great option.
Okay. Unless, yeah, okay. So if I can share screen. Oh, I'm just gonna do it. I've got the permissions. Oh, but I have everything out. Are you guys seeing the screen in a
We
nice
see your
way?
screen. We do
Good.
legislative outcomes.
You never know what Zoom is going to do to you. Except, of course, Zoom won't let me see my screen. And so let me move. I'm going the wrong way. So as you all know, and I've emailed over the past couple weeks, SB 2274 CD1 enrolled to the governor, not without drama. That was an exciting turn of events over the last 2 days. It seems like the bill died. And then thanks for some very knowledgeable and expert legislators, they were able to hold the papers and then get Senate and House leadership and the chairs all working together, and they passed it through. They did remove the workforce survey. There was some folks who were uncomfortable with that. But oops, sorry. But the Board of Nursing, Leanne Tashima, called me right away and said, we will make do and we will make it work. So, you know, good, strong partnerships across our state departments. We got, and most importantly, we got the license fee increase, and that will start July 1st. We would have been in a shortfall this year. The cost of employing the folks at the Center for Nursing is high and a worthwhile cost because they do really good work. But, you know, we couldn't just seek grant funding. That's not the purpose and the nature of this organization, because we have to do the work of nurses and for nurses. And so I'm really pleased with the outcome of this bill, even though we didn't get the survey. I think the strong partnerships will make that work, and then the fee increase will make us be a strong and serving center for years to come. HB 1600 is the state budget bill. So this is the budget that establishes the Department of Public Service and the Department of Narcotics Enforcement Division, and the University of Hawaii General Funds, and DLNR, and every kind of state department there is, DBED and HR, and, you know, energy and transportation and everything. So it has over 100 pages. Actually, it has over 900 pages, almost 1,000 pages. It's a large document. It's hard to navigate. Excitingly, it looks like the agrees worksheet, we haven't seen the final state budget yet, but the agrees worksheet, which is kind of everything that the Senate and House agrees upon, had the 30 actually, it should be, sorry, 39 lecturer positions and the 40 just-in-time training class for new clinicians, which is essentially transition to practice support. It would be 20 trainings per semester, navigated by the Center for Nursing, and then the lecture positions will go straight to each of those schools. That's what it looks like in degrees. And faith shows it. It's exciting. So a couple considerations is this doesn't get us out of the woods. In fact, we're still running from the fire. This is not the end of the story. We needed increased lecturer positions because we've had a shift in the clinical placement construct business model. A lot of hospitals are asking for 6 students to every faculty instead of 8. That's a 25% reduction, and that has to be addressed. And a lot of people aren't willing to take on the full-time clinical role, so trying to make more part-time clinical instruction roles available. And we still need new faculty and more faculty. So that will need to be another request next year to have the state underwrite more of nursing education for University of Hawaii. This also doesn't do anything for our private schools. Our private schools aren't necessarily in a better situation. And I think from a budgetary perspective, you could say they're in a worse position because they don't have the general funds to underwrite their education. So we need to, their education costs. So we need to work with them to find solutions for them as well. This might be a tool to help them go to their administration, but money's money, and you can't, money doesn't grow on trees. So I think we need to work with our private institutions just as much as our public institutions to ensure that they have the resources they need to teach. I sent out a series of unfortunate articles today, all in an email. One of them called for a doubling of the nursing education in order to meet the future nursing needs and the current nursing needs. So with that, we know that we need to help every one of our schools, and we need to do more, not just this, but not looking a gift horse in the mouth. I'm very excited and very grateful. HB 1758 allows temporary permits. I don't know substantively if this will make much of a difference, but if anything, it will expedite the process for foreign trained nurses to become licensed for the first time in the United States in Hawaii. SB 2597 appropriates funds to the state loan repayment program. This is exciting because it's primarily received by nurse practitioners, actually. So it really does help our nursing workforce. I also see that Kelly has joined us. And because of that, I want to respect her time. And the next slides, let me just go through the next slides are the ones that are passed, and then I'll go through the ones that died quickly thereafter. So we have the loan repayment that was that does benefit nurses. And then we have enhanced payments to some nursing facilities. So that will help primarily our long-term care. And then we have a telehealth pilot for rural areas that was funded as well, that includes nurse practitioners. Okay, and then with that, I am going to close my presentation or stop sharing and hand it over to Kelly, who I am so glad is here right now.
Thank you very much, you guys. So I think I can share. I just want to take a minute to say hello. Actually, that was really interesting. So I'll probably stay on to listen to the rest of it.
Yeah, please stay.
How to get updated. So for those of you that I haven't met, my name is Kelly Johnson. I've been, so I asked somebody, when are you Kama Aina? And they said, when you believe that you belong in Hawaii. So I'm officially Kama Aina. And I have an 808 phone number, so it's totally official. Anyway, so I've been here about 1.5 years, and I've actually been a chief nurse for, this is like year 28. So it's kind of been long in the tooth for me, but came from, my original work was in Colorado. That's where I'm from, Colorado native, University of Northern Colorado was my bachelor's degree, and my PhD is from University of Colorado Health Sciences Center, and then moved to the Bay Area two different times, where I got my, received my master's degree in family health and neuroscience clinical specialist, sort of kind of did a dual program at UCSF. My clinical background was in traumatic spinal cord injury, so I have a real passion for the impact of the work that you do on you as a nurse, those of us that are nurses. And so really spent a lot, my PhD was in compassion, fatigue, and pediatric nurses. So this well-being work is near and dear to my heart. I've been at Queens, as I said, for about 1.5 years. The chief nursing officer at the Mana Mana, or the Punch Bowl location, as most people know it, our primary medical center, and then the chief nurse executive for nursing practice across our system. So love it here and honored and privileged to be talking with you guys tonight. So I do have a couple of slides, and so I'm going to share, I hope, here. There we go. Get myself organized here. Okay, can you guys see it? All right. Okay, we'll put it in presentation mode. That'll probably be better. My computer's really slow today. It's must be ready to go home for that glass of wine. Okay. So what I'm going to talk a little bit about is how we're under construction. I want to make that clear up front, that we're under construction for creating and supporting what we're calling a well-being ecosystem. So across our entire system, looking at how we build, support, foster the well-being of our Ohana in the Queens Health System, whether they work in ambulatory, hospital, clinical, non-clinical. We want to make sure that we have absolutely the ecosystem that worries about the health and well-being of everyone that works for Queens. So I thought I'd just real quickly talk a little bit about definitions, really looking at well-being, a state of mind, body, and spirit in which we experience optimal conditions for holistic, healthy living. So we talk a lot about wellness, which is really a set of habits and behaviors and impacting our physical, mental, spiritual, emotional well-being, and then our wellness. And then well-being is that state or condition of living well. And being well is safety, optimum health, and all those dimensions of health. So we are addressing all of those angles of well-being within the work that we're doing, not only for our well-being ecosystem, for our the caregivers. We call everyone a caregiver, no matter what your role is at Queens, but also those principles are being well seated and developed within how we're thinking about what we're calling our clinical programs, our care across the continuum in our population health model, and also within our self-insured program for our employees. So there's a lot of ways that this is utilized in our system. So there's several, frameworks that we've utilized in thinking about how we're going to approach this work. So some of you may have heard about this particular framework. There's a CEO coalition, and it started with 10 CEOs from pretty large health systems across the country. And Vocera is actually the company that convened the CEO coalition, and they partner with IHI. So it's some pretty big hitters out there that are looking at this model. And we really appreciated that it was very comprehensive, not complete, but comprehensive. And they have what they call their pillars. So there's 3 pillars. The first is safeguarding psychological and emotional safety. And part of that's not only well-being, but also promoting safety and quality. So there's several outcomes that are relevant to this, this model impact. But the 3 bodies of work, if you will, under this particular pillar, investing in processes and technology that reduce emotional and cognitive burdens on team members and restore human connection to the health experience. So this is really, all of the literature that relates to how much time people are, nurses and physicians and others are spending with the computer, or the computer between them and the patient. So how do we reduce, or they're spending time with their patients and they're spending hours at dinner or after dinner doing the paperwork and the other things that they need to do instead of being with their home families. So a lot of work around that. And we're definitely looking at maximizing our electronic health record and minimizing the time that people spend in the record. We still currently have our nurses spending about 2.5 to 3 hours a shift in the electronic health record. And imagine what they could do with that time with patient care. And then second, creating policies, practices and policies that advance open communication between teams, members and leaders, so people feel safe to speak up, bringing their full selves to work. So that's a lot about psychological safety and moral agency, really being able to speak up and kind of being big and bold about bringing up tough issues and being supported to do that and not sort of marginalized or rendered voiceless or punished for bringing things forward. And then third, providing resources to assess and support team members' emotional, social, and spiritual health, and alleviating the stigma and deterrence to seek support. So unfortunately, I have to say, in the last 2 weeks, we actually had a team member who committed suicide. And it's a real wake-up call that in spite of everything that we're doing, we still have people suffering silently in pain, and we don't know. And so we know that we have started our work and our supports for our team, but we have a long way to go. And that just broke my heart when I heard that this week. So the other comment I'll make about this section is it really does also align with high reliability and our efforts in our organization to really look at standardized care processes and all of the elements of high reliability teams. And part of that is psychological safety, ability to speak up, having standardized care, daily standard work, all of those things that make the work easier on emotionally and mentally also on our staff. The second is promoting health justice. So this is really, declaring equity and anti-racism are components of safety, requiring explicit organizational and health equity focused policies and practices to advance diversity, inclusion, and belonging. And to us, we've really leaned into the belonging. So really the end being of the social justice is people belonging in the system, no matter their social makeup, their whatever that is. And then the third pillar is ensuring physical safety. So really looking at implementing zero harm program for care team members to eliminate workplace violence, both physical and verbal and sexual, whether from team members, patients, families, or community members. And I don't know about you all in your, your workplaces, but we are seeing amazing increases in really extreme events happening in our organization. It's kind of frightening. So this work, again, we're really working hard on it, but I don't know that we'll ever be done. And our goal really is 0 events. So that's a huge, audacious, aspirational goal that we hope we can meet. We've got to at least reduce what we're seeing. And then ensuring that all healthcare organizations can procure and provide evidence-based personal protective equipment, technology, and processes that healthcare team members need to do their jobs safely and care for patients. So this also gets to, not only infection prevention, but prevention of workplace injury, no matter what the cause. So this is a framework that we have also utilized to make sure that we're comprehensively thinking about what that well-being looks like. And then we move into, we're really fortunate to have Dr. Nalin Andrade. Some of you know her. She's a kind of a pillar in our community and landmark a person who's been working on, Native Hawaiian health at the university, as well as diversity, equity, inclusion, and social justice. And she's become my glued at the hip partner around our well-being ecosystem, because you can't separate it. It's also integrated and intertwined. And this is the conceptual framework that her team that's working on Native Hawaiian health and diversity, equity, and inclusion and social justice have come up. And it fits beautifully with well-being as well. So it's a really nice framework that can be utilized in many, many ways. And the reference on the bottom shows that it's from the Journal of Indigenous Voices in Social Work. And so really working, in the Native Hawaiian culture. And it speaks to optimal health, again, personal balance of mind, body, and spirit, and our connection to resources, people, places, and cultural identity. And so it's going to be critically important that we meld the work of well-being around the work of DEI and J. And I was so struck when I saw this framework presented by Dr. Andrade, and really the center upside down diamond of the Pilina, the relationships and the connectedness that is so important culturally in Hawaii, and so relational to what we're doing in our division of nursing with caring science. And I'll talk about that in a minute. And then the other important thing I wanted to share is our professional practice model. So this practice model actually goes back around to 2004. Some of you knew Dwayne Walker, who was the CNO here many, many years ago. And he worked with a group to really develop the professional practice model. So this starts to cull down from, really big to our individual professional practice model, how we're aligning things. And the takeaway from this is how we really have integrated a lot of the Native Hawaiian cultural practices and foundational beliefs in our professional practice model, and caring science. So the nursing theorist that is at the heart of the Queen's professional practice model is Jean Watson's theory of human caring. And that's the theoretical foundation from the professional practice side of things for nursing, integrated with all of the framework for Native Hawaiian health, as well as our DEI and J work. So some of the exciting work that's going on at Queen's, I wanted a minute to speak to. I appreciate. So we are doing a lot of work around caring science, and it's really something that drew me here, honestly. And I was so grateful that that was a part of the fabric of nursing here already in the Queen's Health System, and something that we are, I guess, reinvigorating and rebirthing here in the organization. And a couple of things we've been able to do. We actually have had great success in our donor community, getting funds to support nursing. So we have something called the Future of Nursing Fund, and there are several other donors who have, we've raised a couple $1 million actually to support our caring science work in particular, and then just our workforce development and development of leaders. And so we've trained 30 of our leaders as Caritas leaders, which is a training specifically for people in formal leadership positions to learn how to lead from a caring perspective and support caring science in the culture and the environment. And then we have one cohort has already started of staff nurses who are going through the program for Caritas coaching. They'll come out as Caritas coaches, and our second cohort has been identified and will start shortly. So we're really excited about bringing that work. The second bullet point, I was fortunate enough to be able to create a position specifically to hire a caring science scholar. And in the position of director, she's really director of resilience and caring science. So caring science is sort of a medium to get us to a state of, resilience and well-being. And so she has a great theoretical foundation to help us move that work forward. Her name's Chris Griffin. She's back on the continent getting her family ready to move here, and they're camping in a house with no furniture right now. So she wasn't able to join us, but hopefully we can have her come and talk sometime. She's just lovely and wonderful. And her PhD is in caring science from the University of Colorado, where Dr. Jean Watson, spent the majority of her career developing this theory. And she, has a deep, rich history in things like workplace violence, incident response, emotional support. So we are really going to be able to accelerate our development of that work at the Queen's system. And then we had an amazing group of frontline staff. There were social workers, nurses, case management, a variety of other folks in the organization that realized we needed to do more at Queens around diversity, supporting diversity, equity, and inclusion, and put together a program and brought it to the senior executive team in the organization, and said, this is what we think you need to do. And we'd like to lead that work. So they actually are the inaugural steering committee that's working with Dr. Andrade on the DEI&J work. So it's a really wonderful story of, instead of from the top saying, we're going to do DEI&J and having it go down, it's really people understanding that we don't have equitable healthcare in Hawaii for Native Hawaiians. We don't have equitable outcomes. We may not have equitable promotion opportunities in the organization. Whatever all those things are, the grassroots development has been amazing. And then I already mentioned we were able to bring Dr. Nalin Andrade on as our executive director for diversity, equity, and inclusion and social justice. And so to have somebody who's at the most executive level driving this work in the organization has catapulted the visibility, obviously with the executive team, but also the board of directors. And so she's just hired another director and putting her team together. So a lot of great work there. We're also very fortunate to have an integrative wellness team. And they originally were convened as a department to provide integrative wellness interventions to patients or for patients. And during COVID, because a lot of it is hands-on, they actually were asked not to be providing services to patients because we were trying to limit the exposure of people. So they sort of pivoted and started providing support services to staff. And now we're at a place where we're probably gonna have to double the team because we can't give it up for the staff. It's been so well received. So they'll do things like, they call them Zen dens. So they'll go to a specific nursing unit, for example, and set up different stations where people can do aromatherapy, Reiki, therapeutic touch, whatever they're offering for the day. And it has just taken off like wildfire. So we're hopeful to be able to double that team so that we can do patients and continue to do staff. We've also had a really generous donor give us money. So we're creating a beautiful outdoor space that's called the Serenity Space. That'll have, like a labyrinth and different benches and kind of places for people to just go have a meditative moment if they have a minute off the unit. And then the Chris Griffin, who I mentioned as the Caring Science Scholar, is actually working at each individual unit level, currently just at our medical center site on the inpatient nursing units to create those Zen den spaces or Serenity spaces on each individual nursing unit. And we're using some of the donor funds that we had. So some of the units want massage chairs. We're going to do, we were calling them caring code carts, but we'll come up with a more therapeutic name. But literally carts where they could have, aromatherapy, whatever they want in their cart, snacks, so that people can actually have access to that, even if they can't get to the room. And then the Ho'omau Care for You peer support. We have an on-staff psychologist who is just amazing. And we actually had two of them in the peak of the Delta and Omicron surge, who are on staff and available to do individual team support for well-being and emotional support. And Andrea Hermosora is our primary psychologist, and she rounds routinely, particularly like on our COVID unit and so forth. And then critical incident stress management. This is another area where we actually had our social workers were realizing how much stress people were in if we had, something bad happen to a staff member, or particularly challenging case on the unit when a patient died, or, whatever. They actually became certified as critical incident stress debrief experts, and they respond for post-incident debriefing. So that was kind of interesting, but now we're going to have to staff them up as well, to make sure that they can continue to provide the social work services they need to the patients. We do Schwartz rounds. I know a lot of people do those, but we went remote during COVID, and it's really been an amazing support group around COVID. And they've actually gone to individual units, like they just did 3 units in the emergency department, specifically to focus on the emotional distress that our emergency room team is facing with, our capacity issues and short staffing and a variety of other issues, violence in the workplace events and so forth. We are hiring what's called a behavioral emergency support team. You may have heard of BERT team, behavioral emergency response team, but we're doing something a little bit different. So it's going to be a 24/7 2-person team. One of the team members 24/7 will be a nurse, behavioral health nurse. The second one, we're still a little bit debating whether it should be a security guard or a second behavioral health provider. And they'll do proactive rounding on challenging patients. They'll do care planning and coaching with teams. They will respond, and they'll respond if there are incidences to do either verbal de-escalation, or they can be involved in physical de-escalation as needed, and also be there for post-event response. So we're really excited we've got nurses on off shift and weekends, but we're going to go 24/7 and round it out so they have a partner with them. And then I have no idea, spiritual emotional care result. I wrote something wrong there, but our spiritual care team does, tea for the soul and blessing of the hands. Again, not things that other organizations don't do, but they're very, no pun intended, religious about providing those services to our staff throughout the organization. And then the crisis counseling, the resilience project, where we actually have had community psychologists prioritize healthcare providers, nurses and physicians to come in for emotional support. And we're rallying the troops again for this next surge. I think this one seems to be the most distressing so far, because I think we all thought we were really at a point where we might get out of the woods. So this one, and it's staff going out and not necessarily patients coming in, but still distressing. So anyway, as far as well-being, we still have a lot of our activities focused on COVID recovery and the impact of COVID, but a lot of it not. It's just going to be work to develop that well-being ecosystem. We have 2 of our sites, our North Hawaii Community Hospital. There's actually a community effort for Blue Zone. And I don't know if you guys know what Blue Zone is, but it's a lot of a wellness focus on, having a healthy community, bike to work, eat well, eat well, take the stairs instead of the elevator, just some very practical things. And then, there's a lot more to it, but so North Hawaii Community Hospital participates as a community participant, and then our West Oahu hospital is a actually designated blue zone facility, and they've seen significant improvements in their staff perception of wellness as they've really hardwired some of the blue zone practices. So, and I just thought this Hawaiian butterfly was beautiful. So thank you. If there's any questions, I'm going to go ahead and unshare so I can see people again. And if there's time, open it up to questions. If not, thank you for letting me share a little bit of what we're working on.
Hi, Kelly. This is Clem. I have a few questions, comments. Great job. I was listening to a HRSA webinar in March, and they said 500,000 nurses left our workforce because of burnout, right? So important work that you're engaging in. So I'm just curious. You have already started your program, but timeline in terms of assessing its effectiveness, etc., and what measures are you using to do that?
So that's a great question, and we're talking a lot about what additionally we should be measuring other than the data collection that's going on over at West Oahu related to the blue zone. There's a lot of indicators that we want to make sure that we are measuring improvements on for our self-insured health program members that are employees. So implementing early intervention for emotional distress and mental distress, but also things like high blood pressure, glucose, and those things. So there's a lot of practical wellness types of things that we're going to be doing, hula for exercise and, healthy eating and all those things. So we'll be measuring those, real biometric indicators for those types of things. Organizationally, we measured burnout. So we measured things in our I don't want to call it an engagement survey, but I'll call it that because that's sort of the intent, but it's got a lot of different measures in there. But we definitely have a burnout problem. It's like 60%. So our staff, our turnover is in nursing is only 5%. Which is fascinating. We have a vacancy rate, though, of about 11%. And part of that is because we've grown so much. And with COVID, we had to change our staffing model and some traveler stuff and all of those things. But our turnover is low. But the concern is people are working burned out. And nurses have higher than physician burnout. And then our APPs are the highest, consistent with nationally. So we will be doing pulse measurements over time. So we'll be able to measure, when we implement certain things and associate that with our pulse, with our pulse indicators of burnout. We need to get a little more sophisticated in some other measures, and that's one thing we've been talking about. So if anybody has any ideas, let me know. But as we implement specific improvements, we'll look at what measures we also want to add.
Kelly, you were included in the email I sent out earlier. But one of the articles was specifically about burnout and intention to leave, and it had essentially their entire tool was listed in the analysis. It wasn't the tool itself, but
yeah,
some of it includes questions about burnout, but also questions about, how well you think you can communicate to your higher leadership. Do you think that your concerns are heard? So those, some of the things that you're addressing, as well as other things like, physical safety, physical distress in terms of injury in the workplace,
Mhm.
as well as staffing ratios and those kind of environmental strategies. So the survey was long and ran the gamut. You might be able to pull some of those questions. And then you'd have a kind of national baselines to benchmark it against too.
Yeah, I'll take a look at it. Thank you. It sounds a lot like, so we do a couple of surveys. So we do what's called standout. So there's a survey there and the score survey. And then, so there's a lot of those questions: teamwork, communication, support by administration. Do I have input into changes in the organization? So they may be similar, but, and we can nationally benchmark there, but I will definitely take a look at that. Yeah, thank you. I didn't have time to read them before now.
So I have a question for you. Because, and thank you, Kelly. Kelly is the reason why the Center for Nursing started the CNO calls at the beginning of Delta, because she voiced the need to communicate regularly with the rest of the nurse leaders in the state. And there's a theme in those calls right now, and it's specifically related to the challenge of recruitment and retention. And then when we talk about that challenge, we hear that it's delay in licensing for people who are out of state or new to nursing. There is the cost of living, and there is, and then there's the kind of stress of being a nurse right now. And I think you certainly have identified a lot of the things that you can change within the organization in this talk, and thank you. Can you share with us the items that you think really need a larger state involvement, that organizationally it's really out of your hands and it requires more people's hands to make change?
Oh my gosh. So there's a couple of things I do think related to workplace violence. We have got to push legislation about reporting, about the penalties to people that are, volitionally violent and hurt people, like they have for the flight attendants, like they have for other people. So now it's a misdemeanor, and the law doesn't really address nursing very well. So we need that. Number two, I do think that we need to, I think we individually, I don't know if it's every hospital, but HPD will not let the hospital file a complaint. And the problem is, when an individual nurse files a complaint against a patient, their personal information is on there. This is a small community, and they're fearful to press charges and some really bad things are happening. And it's not because they're demented. It's not because they're, have a brain injury or anything. These are just people that are really, some of them are very mean. We had one incident where a nurse had to come in and help a security guard, and all three of them got hurt because the patient was so violent. So, and they won't file charges because their phone number, their address, their name, everything's on the police report. So we need to fix that. I think that there are enough graduates on this island that we could solve our own problem. I think. I don't think we have to go to the continent all the time to get people. Yeah, we need experienced people, but until we get that cycle going where we are continually and constantly, and I've been at this long enough, we go through this cycle, like we say this like every time we have a problem, right? We won't hire people unless we have positions, but then we get in this rut where we don't have anybody. So we have to commit to continuing to transition to practice new graduates. We have to find ways to keep these brilliant nurses that you guys are graduating on island and in our workforce. So I think we need to figure out as a state, like I was talking to, Jan over at Molokai, she's in our system. And she's starting to freak out because she's losing 4 nurses. Well, when you only got 12, 4 is a pretty big number of your workforce. And they used to get the associate degree nurses or the new grads because for some reason we weren't taking them. And now we're taking them. She can't get anybody to apply on Molokai. So how do we do loan repayment? How do, you know, some of that the state could help us, right? Let's pay off loans for people. Let's look at how we can support our rural health partners. How do we have a centralized way to do a lot of the transition to practice training where the burden isn't on individual, especially small and rural hospitals. I think we could galvanize around that. I know we have the platform, the HealthStream platform, so we're all kind of on that. Could we centralize some CareLink training? Or not CareLink, but Epic or computer documentation training? Could we standardize the background check information for if we do have travelers and they, go from one place to another? Do we all have to really go through all of that again? I think there's lots of ways we could expedite. We did have a ton of challenge with the licensing, and I do think that, allowing a temporary permit or license until somebody can, if they have an active unencumbered license somewhere else to do, not compact state, because I know that we are kind of, that's not favorable here, but at least a temp license so we can get people to work. The housing is an issue. We can't fix that, I'm afraid, in my lifetime. But if we hire people who are from the islands and have living arrangements, that would help us a lot. And it's not just nursing. I mean, we are suffering everywhere. We have over like 60 physician practice associate positions right now. They're dropping like flies. And nursing assistants, dozens and dozens of openings. So we have nurses that we can't afford to lose sitting at the bedside in our one-on-one max sitters with suicidal patients because we don't have sitters to do that. Rad techs, surgical techs, phlebotomists, pharmacists, the list goes on. And I know you guys are nodding your heads. It's the same thing kind of everywhere. Okay, I'll get off my soapbox.
Kelly, well, thank you so much for joining us this evening.
Sure.
And sharing all the information that you guys are, the hard work and all the initiatives that you guys are undertaking there at Queens. It really is impressive, and it does require a lot, especially with the organization your size, with all the individuals that work there. It's natural that's something that we can learn from, and then kind of pick off that information as well, what we can implement in other areas. So again, thank you for sharing.
Sure.
This evening.
I think also another thing, with Chris on board, Chris Griffin, we could do a lot, Laura, at the center, offer continuing education type things. If there's wellness, resilience, or even, how do you integrate care back into your practice? She's a brilliant educator. That's her sort of background, and we are happy to share her at the state level.
Well, thank you. And we'll be taking you up on that.
Good. She's a Caritas coach trainer and all those type. She's on staff at the Watson Caring Sciences Institute. So, yeah.
Yeah. Thank you very much.
Sure.
All right. Well, thank you again, Kelly, for joining us. Why don't we go back to Laura, and then you can give us the update in regards to our legislation and policy. And again, Kelly, you're more than welcome to go ahead and say this is a public forum, so you can go ahead and stay for the entire duration, or you can dig out if you'd like. But again, we encourage you to stay
for a while anyway, if you don't mind. Thank you.
now. Of course, thank you.
We very rarely have public guests, so you sing with us. That's a treat. Let me say I'm not muted. Yes. So as I was saying, there were some increased funds one time for skilled nursing facilities, foster care, as well as expanded adult residential care homes. This is really important because there's a lot of revenue losses in these areas. One of the common themes in the CNO calls is that a big challenge across our state is acute care facilities' inability to discharge their patients to the next appropriate setting. And so if we lose more of these facilities or post-acute care facilities or home-based facilities, that problem is only going to get worse. And then it causes a kind of a cyclical problem, not just not having enough beds, but it creates revenue challenges across the board. And that's bad. You know, we have to pay attention to the business model as well. So HAH put this in at the last moment. They got it through. It's a really big achievement. That will be really good for the community. I hope that we can learn if there are any of these fees that can be made permanent, or how to improve revenue for long-term care and post-acute care in general, because they're challenged with workforce greater than acute cares are. As I mentioned, the telehealth project outcomes, I actually just want to go back. The loan repayment does include physicians, nurse practitioners, physicians assistants, psychologists, but also social workers, marriage and family therapists, registered nurses, and it's for rural and underserved areas. And so I just wanted to mention, because Kelly, you mentioned loan repayment being good, the state actually did just fund such an initiative. I'm going backwards. Okay, bills that died. There was a rural health task force, what we call for the Canoe district, or that Hana, Mulka'ila, Nai area. It died. The Center for Nursing was actually tasked to do the work. It would have been a big undertaking. It's worthwhile to do it anyway. So I will be contacting Hawaii Primary Care Association and see if they have the will and the want. I also think it would be a great student project, and perhaps we could find someone who would want to support that if that's their passion area. Our Care Choice died. Like the Center for Nursing, it had it had moved through. It had a lot of support, less so on the House than the Senate, and that's usually the case. It had aimed to add APRNs and PAs as eligible providers, as well as decrease the wait time, not the wait list. I'm sorry about that, the wait time. It died in conference, and there's questions about how and why it died. HB 3208, which is the preceptor tax credit. This is the third year we tried. The first year it died because COVID started. The second year it died because the state got ARPA monies. The third year it died, we don't know why. But it's going to sunset in 2025. And so instead of going for it again, we're just going to prove the concept and then ask for all of the changes when we seek to renew. So we're just going to do a good job with what we have moving forward. 2187 would have, this was a school-based health bill. It would have added APRNs to the folks whose prescriptions can be accepted in the school-based system. So DOE, that wasn't necessarily substantive because it already had language that said other healthcare providers. What was substantive is right now only public health nurses, or it says the Department of Health, can authorize medication administration. So imagine your kid at school, if you have a longstanding chronic condition, maybe seizures, maybe you have asthma, you most likely will have had a plan put in. It's called an IEP. You will most likely have a plan in place where this medication administration is processed. But if you have a new condition or like acute episodic, it's likely that your antibiotic course will be done, or your steroid course will be done by the time these are processed. Because, and Gloria is here today, she knows about this more than I do, but because resources are limited and there are so many schools and there are so many students who have these requests. So this effort would have been to allow more qualified people, in addition to public health nursing, to engage in this process to kind of relieve the burden off of public health nurses who've been doing a great job. But we do have a large and robust school health service section now with Hawaii Keiki, as well as the FQHCs who have direct DOE contracts. The bill didn't go through, primarily because I think the House perceived this to be a scope of practice issue, which I'll talk about later. And I'm horrible with, I'm saying it should be SB 2187. I apologize for that. HB 1985 and SB 2602 would have established limitations to mandatory overtime and voluntary work hours for RNs and LPNs. This bill didn't get any headway. It was an initiative of HNA, and I know Linda and I worked with HNA in advance. They were modeling this off of Alaska. So I provided the evidence, and I provided the evidence to that I could find. Being at the university, we do have the benefit of having the library. So we were searching for information. I think and then Linda did a lot of work in terms of the policy and the process and the strategy, helping HNA learn as they're endeavoring to get into policy. I think one thing that is important about this is that staffing is a commonly discussed challenge with workforce wellness. And I think it's a problem. That article I mentioned earlier, they mentioned one of the primary factors that has contributed to workforce wellness or loss of workforce wellness is staff feeling burnt out and staff feeling like they're understaffed. But I think there's a lot of different strategies, and I think it's important to look at the evidence-based staffing models, and if it's the right action is legislative action, or is it staffing policies? Is it creating a statewide plan? Is it having a repository of the evidence-based practices? So going back to the nursing process on this, the legislature didn't touch it. So I'm making these comments specifically because if the legislature doesn't have a will, and there is still a need, then there has to be, then you have to go back and do the assessment, and you also have to go back and look at the evidence to figure out what is the right thing to do. And I think this is a very hard topic, as Kelly just described, because we have a workforce shortage. And so how do you do the right thing when you don't have enough of anything? And I think it's an opportunity because you can build the house up the way you want to see it, brick by brick, but it will be a hard challenge. Clinical laboratory director was the next HB 1667. It was proposed to be established in statute. Right now, it's only in administrative rules. This would have improved some clarity for pharmacies, essentially, but it would have lost the ability for APRNs and others to have CLIA waivers. And CLIA waivers are what is necessary in order to provide things like a pregnancy test in a private practice. That you need a CLIA waiver to do that. So it could drastically reduce access to care if the right list of folks are not included in the statute. And so they're going to be working with the Center for Nursing to make sure that that language is in place when they go and try for it again. They're going to use a more interprofessional approach next time, which is great. There were some interesting resolutions that were introduced this year. The titles are what you see in all caps here, and I'm going to go and talk about them specifically because they were very interesting, and it was kind of outside of the norm to have this many resolutions that specifically looked at APRNs. The APRN and PA, or not APRN, sorry, nursing. The APRN and PA scope resolution, HCR 139, did not, it's a concurrent resolution. The C in all of these means that the the House passes it to the Senate, or the S passes it to the House. If you see an HR or an SR, it only stays on its respective side. So because this is a C, HCR, the House agreed upon it, and then they sent it to the Senate. The Senate didn't agree. And so it was not adopted. We're going to work on it anyway, because it is very clear that the House has interest in this and they want to learn. They took basically every single bill that introduced anything related to APRNs or PAs and asked for more information. They also, the House also reached out to HAH and asked for employers to clarify, like, are your employees really doing these things? So, and that was an interesting approach. And I thought it was a good effort on the House to validate that this is not just not just a gold standard, but also relevant. And I think that's a good thing for them to ask. It will be important to help our current legislature understand what nursing practices and what APRN practices, nursing overall, and then specifically APRN. There is a need to clarify that our scope of practice is kind of the sun, and all of these other statutes that may or may not list APRNs reflect, it should be gravitated, it should be reflected upon the sun, the scope of practice, the Nurse Practice Act. So it's not expanding scope of practice, it's recognizing that the statute that was last updated in 1992, and our scope of practice was updated, we got full scope of practice authority in 2009. If that law in 1992 wasn't updated to match the Nurse Practice Act, then that is obsolete. It's not expanding it above and beyond the Nurse Practice Act, but it's saying that hasn't been updated since 1992. We just have to update it. It's not scope expansion. It's updating obsolete laws that no longer reflect the Practice Act. And I think there's some really novel ways that we can communicate that might help with understanding. So we're invested in doing that work. We're going to be working with the Board of Nursing. I'd also like to work with a nursing student. I think this would be a great project for a graduate student in nursing. UH West Oahu was really a topic of conversation for Anne, for Roberta, for Linda, and for Gloria. You guys, during your confirmations in the Senate, you had a lot of questions about this. Thank you for answering them. You guys did great. The Senate really wanted and was upset with UH that they did not continue the nursing program at UH West Oahu. And they asked that the UH system look at relaunching nursing education on the West Side. At the end of the day, what that ended up being is that it was requested to establish or seek partnerships for a permanent nursing program. So that doesn't necessarily mean that UH West Oahu has to have their own program, but maybe they partner with Hilo or with Manoa. I just noted here in the orange box that we do have work underway to assess the clinical placement capacity. So what is the cohort size that our programs are looking to enroll over the next 5 years? And then we will take that back to the clinical facilities and say, like, is this going to meet your need if you have this many graduates? Are you going to, or are you going to need more? Or is this going to break the bank in terms of clinical placements? Because it is really, it's kind of a chess game. That can be useful with this UH West Oahu conversation. And then we have every year, Carrie puts out an education capacity report for the academic year prior. So she just got all of the surveys in. We had 100% response rate from all of our schools, which is fantastic. So she's working on that report and she'll have that finding out as well. So those resources can be used by the university and we'll make sure that they know that they're available. Same thing, Honolulu Community College had a very similar request, maybe not so much attention as West Oahu, but there was also interest. The SCR 215 of the 4 resolutions and concurrent resolutions is the one that passed through. So it did have Senate and House agreement. So University of Hawaii is going to have to respond to the legislature about their capacity and the feasibility to launch a program at Honolulu Community College. So that is something, we have the same resources. I also know that other programs are also looking at increasing their capacity or being asked to double, triple change, do back flips, do front flips. Everything is being asked of nursing education right now. So all of these resources are meant to be informative. As nurses, we assess first. So we have to have the data and we're trying to provide the data so that there is proper planning. We're not necessarily doing the planning, but we can make those resources available. It's a very tenuous time in nursing education. We have so little nursing faculty, and we have such great demands to produce rapidly. And so that engagement from clinical partners to ensure that there is, that there are nurses who are interested in teaching that are getting part-time jobs or starting to move into academia in shared roles or moonlight roles, whatever, as well as that clinical education capacity, it will be critical for the state of nursing in our state. All of the bills, all of the resolutions are on the Capitol website. So I just want to provide that reference to you all. Does anybody have questions?
Laura, so I think the loan repayment, what was that? It's only for the advanced or graduate level, not
No,
for undergrad, right? Or is it for undergrad too?
RN. It has to be in
Is it?
underserved areas though, Clem.
Oh.
So I think that some urban Honolulu can get underserved because, like Kalihi is a designated underserved area. I think even Queens, like Queen Emma Clinic has, but primarily you're looking at areas that are rural, remote, or federally qualified as underserved. So that HRSA, underserved or medically, MUA and MOOP designation, which is essentially everywhere on any island except Oahu and parts of Oahu. Like it's feasible for people to get this claim. The state monies, I believe, requires a match. And so there are initiatives, the Hawaii State Rural Health Association has funds, and then other organizations sometimes will match themselves for their employee. There have been individuals who have found their own money to be a match. And sometimes there will be other resources found as well.
What's the process, Laura? How do we find that out? Like if there was someone interested?
Kelly Withy,
Okay.
it's on Kelly Withy. You just
All
Kelly
right, got
Withy.
it. All right.
For everyone who doesn't know who Kelly Withy is, Kelly Withy, I joke, is the physician me, but she is the director of the Hawaii Pacific Basin Area Health Education Center under JABSOM. If you Google Hawaii AHEC, AHEC, there is a loan repayment link on her website. And then for people who know Kelly Withy, you can email her directly and she'll hook you up. And I'm happy to make that connection. Yeah, but she runs the program. The program is under DOH, and then she administers it. And then the primary recipient for the federal loan repayment program happens to be nurse practitioners. Or last I heard, that was the case. And she's done a really, really good work to make sure that more and more and more professions have access, and that there's a steady stream of money so that it's funded. The loan repayment program is funded and people are receiving that pay down.
All right. Any further questions for Laura regarding the legislation and policy information that was provided?
It was awesome. Congratulations. Thank you so much.
Yeah, thank you.
Good job.
Yes, great work, great work.
All right. Brianne, if you could go ahead and give us some information regarding the recruitment and retention information for the Hawaii Nurse Residency Program.
Hello, everyone. Can you hear me?
We can hear you.
Hi. We have sat through other meetings that we have had. So some of this will be kind of a general update on where we are. Some of it will be new information. Essentially, most of you are all very familiar with our Hawaii Nurse Residency Program. It has been operational since 2012. That falls under our HSCN mandate to develop a plan for implementing strategies to recruit and retain nurses. Obviously, this is a very important topic, recruitment and retention, as we have noted already in this meeting, and has come up as a important topic in nearly every meeting that we have had during the COVID-19 pandemic. The issue becomes even more critical as we go on. We are seeing nationally our retention rates change as they're being recalculated from the pandemic. And our figures are truly distressing, and never have new grads needed more support than they currently need now. I can give you an overview about why we need to have nurse residency programs, but we really don't need that. And I'm going to try to abbreviate everything since we're a little bit behind schedule. Essentially, at the end of the day, at the center, we are very proud of this program. It was the first in the nation to have a statewide collaborative. We have seen some really promising expansion of the program during the pandemic, and that is a time when this topic has become really important to everyone, trying to provide those additional supports. At the same time that the pandemic was starting, we were also looking at changing our tools from our previous tools that we were using, which was Vizient, to a new product to help support some of our partners. This was actually suggested by Hilo Medical Center and Arthur. Thank you for that suggestion, who had already started using a HealthStream product, which was newer on the market and had a lot of the things that we had set out to identify as being really critical moving forward. And the most important parts of that were to be able to have standardized preceptor training. It was one of the things that we had been talking about for many years and realized was really important to have access to. Obviously, we wanted things to be, to have data analytics and reporting, but we really, really, really needed preceptor training. In addition to that, we also wanted to have some tools that had expanded competency checklists and some skills actually included in our nurse residency programs. And we were able to meet all of those needs and more of those needs with the HealthStream product. That does not mean that it has been easy for everybody to make the transition over. It has been a grueling 2 years for all of those folks who have been setting up new programs. Around about that time, we also worked on negotiating to try to reduce the price of these products. Our previous product was very expensive. At the end of the day, Laura worked really, really, really hard to be able to cut the cost of the implementation down tenfold, and ultimately about $150,000 worth of savings she managed to negotiate for us with making this transition to a new product. Now, our new product has a different kind of payment feature in that instead of having an annual flat rate cost, which was really advantageous for our larger medical facilities, but disadvantageous for our smaller facilities who may not be able to put more than a few nurses through a cohort at a time and couldn't afford the overhead of a previous product. So this way, they pay for what they use with the new product. And it does make things a little bit easier. What we get out of that is a nurse residency pathway that is a little bit more up to date than our previous product. It has dashboards, it has checklists. It can, for some of our facilities, have successfully integrated into their HR systems. For some of our other facilities, we're still trying to work out some of their dashboarding to see how they can make it easier and reduce redundancy. It also has preceptor development, and it has this product called Jane, which allows the nurse residency pathway and the preceptor development to communicate with each other to help match really good preceptors to their nurse residents. In addition to that, Jane also is intuitive in that it does assessments against how the nurse residents are doing during their 12-month program, and actually helps to measure any kind of deficiencies or deficits, and provides recommendations for how education teams might be able to fill those gaps. Not all of our partners who are currently making this transition have transitioned into using Jane, but we have the majority of our partners who have started to implement this new kind of AI product into their nurse residency pathways. At the same time that we were all exploding due to COVID, we also worked very hard to try to access any kind of available funds that were there, because we knew that we had this kind of increased desire to be able to put nurses through. And we were also changing to a new product, and we wanted to try to find a way to fund the transition to a new product for partners. So Laura worked really hard on very last minute for getting a workforce development council grant, which was kind of an up all night overnight task. It was kind of grueling to get that out there. But through that grant that we received last year, we were able to train 100 preceptor resident pairs, meaning that we paid under the grant and those were divvied up across our partners. We also were able to secure a Department of Health ADAD, so that's that
Alcohol and
opioid.
drug.
Yeah. What was that?
It's the alcohol and drug addiction.
Yeah,
division.
alcohol and drug addiction division. And through that, we were able to get a grant to help us implement standardized opioid education content into our nurse residency programs. So essentially what that means is that all of our new grads are getting standardized opioid training, and all of our preceptors who are going through the preceptor pathway are also receiving that same standardized training. Through that grant, we have been able to, as of yesterday, to train and to cover the costs, the direct training costs for 310 new grads and 266 preceptors. So in addition to the funds for the first 100, we're able to help cover some of these additional trainers and trainings. Granted, we're not able to cover any of the HR costs associated with the burden of having nurse residency programs for our provider partners, but those direct funds have been helpful. Every little bit counts. At this point, the grant is due to close in September, and we have currently utilized or encumbered 91% of those grant funds. I anticipate a couple more cohorts from a couple more of our partners actually maxing out, and hopefully we will see that go up to 100% very quickly. Overall, let me kind of like work through this. Some of the biggest highlights that we have overall with our program outcomes are the fact that having the availability of funds and having a tool that can be priced differently has allowed us to expand to our smaller partners and our alternate clinical settings. It also has primarily allowed us to include more partners in our neighbor islands. And that has always been a really important goal of the HNRP, generally speaking. So overall, that's a 150% increase in our neighbor island partners, a 75% increase in our overall partnership. So currently we have 14 current members, and 12 of them are using our new HealthStream tools. We have 2 members that are using alternative tools or the previous Vizient tool, kind of a custom model. As of today, it's 1,569 new graduate residents trained under the time of the HNRP, and we're very, very proud of that. And of that, what we have been able to see transition in 2021 and 2022 is that 20% of those are from our neighbor islands. So we have increased access to nurse residency programs in those areas, and that really is the key. We have thank you to support from Hilo Medical Center in helping to onboard HHSC Kauai. That allows us to expand to more community-based critical care access hospitals, and that is another very important partner that we're very glad to have on board with us. And they are in the middle of their inaugural cohort. It's a very small one, but it's very meaningful. Obviously, we know some of those leading drivers. We know that that we have been able to expand to new facilities because we've had the availability of funding. But essentially what's driving all of these increases really are primarily our nursing shortages. And it's that demand that is also exacerbated by the pandemic. We've got our new grad retention rates, and we can kind of see that we have seen our membership spike substantially. We have also seen our retention rates stabilize into a very impressive rate. This is about 15 points above the national average. And so generally speaking, we always do better than the national average, but we have seen that increase dramatically over these past couple of years, despite the fact that we are seeing such a huge purge in the nursing workforce in general. But we're currently seeing those new graduate nurses being retained in those first and second year. Unfortunately, we don't measure beyond that. Maybe someday we'll be able to kind of expand those metrics and collect that data. Really quickly, before I hand over things, I'm probably going to take another minute or two just for some other major highlights. Because we have this nurse preceptor pathway, 2021 was our inaugural year. And at this point, we have seen 332 preceptors being trained in 2021 and 2022 under this new program and under this standardized training. It is a 5-week model. It's a self-paced model. It is all computer integrated. And so it really does allow a working nurse to be able to have the standardized content and also helps bring them into the fold of that pathway. And 100% of all of those preceptors have been trained in standardized opioid training thanks to the grant that has been provided. Other activities that have been going on that fall kind of under the recruitment and retention umbrella. These are not things that are my activities, but these are things that are going on in the orbit that sometimes we don't ever get the opportunity to talk about. One of them is the reoccurring statewide CNO meetings that Laura mentioned earlier. Part of that is discussions heavily around recruitment and retention. Those meetings are very important to bring people together and identify where things need to go. Currently, there's a manuscript being written for publication for the HNRP. So that's another exciting thing that we're working on, is making information available to the larger public. And hopefully that will be due to be published. We'll see. We'll keep you updated how that goes. Laura worked on doing an assessment of specialty nurse needs for Hawaii. It is a fantastic assessment. It helps to kind of bring into the fold this prioritization of transition to specialty, which is something that was brought up in CNO meetings and has become a very important topic. Really interesting to see where that's going to go with us in the future. We also have that fantastic new graduate RN workforce report that was prepared by our researcher, Carrie Oliveira. Thank you, Carrie, so very much. That's really exciting. It's just come out. If you haven't read it, I do hope that you put your eyes on it. It gives you a really good picture of kind of what those new grads look like in our workforce. And we also have other things that are going on that are kind of a little bit related to clinical placements, obviously, but they do tend to bump up to NRP, and we're working on doing analysis and assessment of our clinical placement capacity planning for the long term. And also as part of that, we will also include some consideration about potential NRP conflicts when we're looking at having that clinical time. We see our education teams get busy with NRPs, and that sometimes has an effect on our clinical placement availability, but those are things that run hand in hand and also are about supporting recruitment and retention. So that's it for me because I am out of time. Does anyone have any questions?
No question, but just impressed.
Okay. I would really like to maybe see if Arthur, if you have any comments or opinions, because you are here with us today and you're using this product or have potentially benefited from these grants, if there are negatives or positives or any comments whatsoever.
Yeah, all positives.
All positives. I like all positives.
The preceptor training and the competency checklist, I think that those are the biggest piece of it that we benefit from it.
Yeah,
Um,
those really are major things all the way around. They were something that we were always looking for. So I'm glad that's there. The tools are not everybody's having as easy of a time as you are with implementing it, but generally speaking, everybody got their feet up off the ground, and just it's a very impressive what all of our facility partners have
Right.
been able to do during the middle of a pandemic.
We use HealthStream for basically all our education. So it's the same platform, and everyone can understand, and they get it. It's easy enough to comprehend.
Could the schools be shared the competency checklists? Is there a way to see those kind of, just see how we map?
Well, the interesting thing, and that's kind of part of the next phase of this whole project, is that we at the center will have our aggregated data. We'll have an aggregated data dashboard. And part of the benefit of better resources and better data analytics is the fact that we will have the capacity to see, not that we would ever call anyone out, but we will have the capacity to see how nurses from certain programs are doing across the state. And also that will really kind of help inform that academic practice partnership with our HNRP, and hopefully reinvigorate the academic council, which is part of that HNRP structure, so that we can start having those really meaningful conversations and have them actually be data-based. So that's the next phase. You have to help me recruit for that, maybe, our new academic partners.
All right. Well, thank you so much, Brianne, for sharing all that information with us this evening. All right. We're running a little bit behind here in time. So just I want to go ahead and turn it over to Laura here about our leadership positions. We have nominations and voting. So we can at this time nominate any other individuals. Again, this is for the chair and vice chair for the Hawaii State Center for Nursing Board.
Anybody out there willing to put their name in the hat?
And technically, this is for positions that start next fiscal year. So anyone who's brand new can put their name in the hat too.
Mm-hmm.
Oh, that got Roberta's hand up.
Yeah, I'd be willing to serve in any way that's appropriate. I know-
Okay. Would you like to be on both ballots?
I think vice chair makes more sense since I'm a beginner and still learning, but I'm open to whatever you need.
Okay.
Great. Thank you. Okay.
Give me just one moment. I'm updating the ballot, and we're about to, anybody else out there interested?
It's fun and it's enjoyable. Trust me.
Okay, so I will, at the bottom of your screens, let me go back to, you should see a button for polling. This is the first time we're trying this method, so hopefully this will work. As a reminder, voting is only for voting members. So that means that our folks that are with us that are not voting members shouldn't use the ballot. It is anonymous, so please feel free to all cast your vote, and we'll see how that goes. We're just going to take a minute or two, if everybody
Oh,
will.
I can't see the ballot.
Yeah, there.
Oh, there we got him.
So my understanding, if we can just clarify, is that new members can run for the office but cannot vote in the election. Is that correct?
That is.
I think that's
It is-
technically true, but
Yes.
Conflict of interest.
Okay.
maybe I didn't think that one through and I threw everybody else's name in the hat. I do have my Robert's Rules of Order. I can look it up.
Okay, I'm a few votes short.
Ex officios don't vote, right?
That's
Excellent.
correct.
That is correct.
Well, we have quorum on each of those. Do we still have quorum? There's,
There are five voting members with us.
oh yeah,
tonight.
then everybody's voted in.
Okay. Can you see the ballot? I'm curious as to what you can see. No,
Yes.
you can? You can
Yep.
see okay. So what we have is currently I'm showing 100% voting for confirming and Schadenhorst, and I'm showing 80% to Bonnie and a 20% to Roberta for the vice chair position.
I think,
Woo-hoo.
well, thank you, Roberta, Bonnie, and Anne for being willing to be nominated or nominating yourself. We can share the results. And we will work with all of our new board members and our new chairs and vice chairs on onboarding in the fall.
Fantastic.
Congratulations.
Congratulations. New business. Or what do we got?
All right.
Just a
There's a
reminder.
conference. The National Forum of State Nursing Workforce Centers Conference is going to be June 20th through 22nd in Bellagio in Las Vegas. Arthur is going to be coming with us, and then Bonnie is going to be attending virtually. Carrie, Oliveira, and myself are there's only 2 members now. The forum changed their membership structure. She's so active. They really do a lot with research. So it's really integral to her role, as well as mine. So we will be going, and I somehow, no good deed goes unpunished, will be presenting each day of the conference. So no expectation that you go to my presentations, but there will be preceptor tax credit, nursing faculty shortage, and kind of like envisioning a new approach to data.
Good. Okay.
Carrie is going to be doing a webinar on the new graduate RN workforce in Hawaii report that she just released last month. If any of you guys have seen her present, she is an expert presenter. She's fun to listen to, and she will have a great presentation. There are CNEs associated with this. It's going to be on May 31st, and there will be an enduring activity that will be recorded afterwards. So if you miss this, you won't miss out. Our next meeting, we usually have it. Oh, it's on August 20th. It's not on the weekend. We will give you.
That is an absolute error on my part. That should say Saturday, August 20th.
Okay.
Oh my goodness.
Yes, it's
everyone. I'm so
August,
sorry.
Saturday.
It is Saturday,
yes.
August the 20th.
We meet on one meeting a year. We meet on a weekend to do more strategic planning. We will do that on Saturday, August 20th. We're still looking for a nice venue to have that meeting, and we will let me know or Bree know over the summer in the next 6 weeks or so if you have any ideas for strategic planning. We haven't done strategic plans since 2018, so we may want to talk about doing new strategic plans, or we may want to wait a year or two after all of the changes that have happened. But that is a meeting where we get to know each other a little bit more, and we also deep dive into the issues.
Laura, can you send out the agenda and the minutes from the last meeting to see what we were talking about and working on?
Yes.
Okay.
Bree, can you send out those agendas? They're also, Arthur, all of our minutes are posted on our website as well.
Okay, I'll just go in there and look.
Yeah.
Arthur, I sent out another email earlier today about the minutes. So you should have that in your email from earlier today.
All right, great. Thank you. I'll look at it. Thank you.
Another thing that I really quickly wanted to say with regards to the next meeting is typically normally for those folks that are off island, we do try to bring you over. Laura, is that still the plan? Okay, so we will try to pick our place ASAP so we can get you sorted with travel for those that would like to attend in person.
Yeah.
Thank you. The 8:30 start time is great. Any earlier might not make it.
Oh, we won't do that.
Well, no, normally there's a half an hour buffer in there for just drinking coffee. So
All right. You need
Um,
coffee.
I see that we have, I don't have Kelly's slides as part of our, she did not provide those to me, but I will follow up with her to see if she'd be willing to share those with us, so we can send them out. I know there's a lot of really valuable information in there, so.
Okay, well, thank you all again for joining. Are there any other announcements this evening? All right, it is
I have
7:04.
an announcement.
Go
I
ahead,
just want
Laura.
to let you all know that Catherine is going to the Wharton. You got to finish the words for me, Catherine.
AACN Wharton Executive Leadership Program in August.
So that is
Sounds
very
cool.
prestigious. If we can give a round of
Yay.
for Catherine.
Catherine, you might want to touch base with Pam Smith. She's also going in this fellowship. this
Oh,
fellow
fantastic.
cohort.
Oh, perfect. I will. Thank you, Roberta.
You're welcome. And congratulations. I was a fellow years ago and it's well worth the time and effort. So good for you.
Thank you.
All right, well, we'll see you in a couple months. Thank you all for your time this evening, as always. Maybe one day we'll be able to be in person together. I also want to say, and I don't know if they're even here with us anymore, but a hui ho to our longstanding board members who are not on the line anymore, but Beth and Susie were with us for, I think, 12 years.
Wow.
So they just did an incredible job, and we really appreciated their time with us. So, yeah.
Great.
All
Thank
right,
you.
everyone. Thank you so
Thank
much. Y'all have a
you.
wonderful
Good
summer
night.
as well,
You
okay?
too. Thank you.
Bye.
Thank you, everyone.
All right.
Bye-bye.
Bye.
Bye.